Hello everyone. So today we will be starting with our much awaited session, chanting part 2. Okay. So in this we are going to do Mullerian anomalies, primary amenorrhea, secondary amenorrhea, intersex, oncology and contraception. All this will give us 10 marks surely in the exam. Okay. So let's start it. Now, see, we are starting with Mullerian anomalies. So here on the screen, it is development of the female genital tract. Okay, so first of all, these are the structures which we get on these are the structures which are present at 6 week in both males and females. Both these structures are present. These structures comprises of this globular is the genital ridge, right? And these are the ducts. Okay, the duct which is near the genital ridge is the mesonephric or the Wolffian duct. Mainly in the normal circumstances, this duct forms the male genital tract. So you can remember this by M for male and M for mesonephric, and all males are wolves. Okay, and the duct which is besides it is the paramesonephric duct or the Mullerian duct. So you all know the chapter name is Mullerian anomalies. So Mullerian will be forming the female genital tract, and as it is para-meso, it means it is on the side of the male, para-meso. So it is a paramesonephric duct is a girls are always on the side of the males, so it is a paramesonephric duct or female duct, and in the last it is a urogenital sinus. And let's see how as such the whole external and internal male and female genitalia, how is it formed. Okay, now let's see. First of all, we know that males they have Y chromosome, XY chromosome, and females they have XX chromosome. Okay, so on the Y chromosome there is a gene which is known as SRY gene or TDF gene. Okay, SRY full form is sex determining region of Y, and TDF full form is testis determining factor. Now this gene acts on the genital ridge, and it forms testes. Okay, now this gene act on the genital ridge and it forms testes. Okay, now in the females who have XX genotype, in them this gene is absent. Okay, this gene is absent, it is not present. This Y chromosome is not present, so how SRY gene and how TDF factor will be present, right? So basically this is absent. So the genital ridge is not converted into testes, rather it forms ovary. Okay, so if the Y chromosome is present, then only the if the Y chromosome is present, then the if the Y chromosome is present, then the genital ridge will change into testes. Otherwise, defaultly, what does the word defaultly means? Automatically. Automatically, this genital ridge, in the absence of the Y chromosome, will form the ovary. Okay, now the testes they have two type of cells, Sertoli cells and the Leydig cells. You all know it. The Leydig cells they form androgen, the Leydig cells they form androgens, and the Sertoli cells they form MIS. Okay, so these yes, this androgens, what do they do? They help the Wolffian duct to grow and form the male internal genitalia. Okay, MIS is Mullerian inhibiting substance, or sometimes we also say is MIH, Mullerian inhibiting hormone. Okay, and we also say is AMH, anti-Mullerian hormone. Okay, these are all the name of MIS. Now, function of all this is that it regresses the Mullerian hormone. It regresses the Mullerian hormone. So I think now it is clear to you what is happening around you. Yes. Okay, now What happens to the genital ridge which has become ovary? Now, in that genital ridge which has become ovary, there will be no testosterone. Now, that genital ridge in which ovary is formed due to the absence of Y chromosome, due to the absence of testosterone, as a result, the Wolffian duct will regress and the Mullerian duct will grow, because as there is absence of androgen and there is also absence of Mullerian inhibiting substance. So now the Mullerian duct will grow and form the female internal genitalia. Okay, so the whole crux of the story is that Y chromosome and their derivatives, they change that undifferentiated form which we studied: genital ridge, Wolffian duct, and the Mullerian duct. Y chromosome and their derivatives changes three things into the male genital tract. Okay, male reproductive system. And when these Y chromosome and their derivatives are absent, then defaultly this whole structure gets converted into female internal genitalia. Needless to say, Y chromosome is a sex determining chromosome. Okay. Okay, so this is what happens. Now, let us see what all structures the Wolffian duct forms. The last part of the male genital tract is mixed with the urinary system, right? So, what all structures the Wolffian duct is forming is, first of all, its mnemonic is 7. Okay, seminiferous. S stands for seminiferous tubule. E stand for epididymis. V stand for vas deferens. E stand for ejaculatory duct, and N stands for again seminal vesicle, though it is not sounding same, but you can remember it that after ejaculatory duct seminal vesicle will come. Okay, so male genital tract, all the structures, they come from the Wolffian duct. Okay, now let us see what all structures the female genital tract is forming. Okay. Okay. Now, female genital tract, as you have seen that genital ridge has formed the ovary, Mullerian duct form fallopian tube, uterus, cervix, and upper two-third vagina. Okay, upper two-third vagina, up till upper two-third vagina, Mullerian duct is forming the whole structures. Okay, urogenital sinus, it forms the lower one-third vagina. The Wolffian duct, which regressed in the females or XX genotype, they form remnant structures, and those remnant structures are known as apophuron. Apo means above, so the structures which is above the ovary in the broad ligament, that structures is known as apophuron. The structure which is besides the ovary is known as paraophron, and structure which is lateral to the vagina, upper vagina, is known as Gardner duct. Okay, and sometimes this duct gets obliterated, so it forms a Gardner cyst. Usually this Gardner cyst comes in the differential diagnosis of cryptomenorrhea. Okay, it usually comes in the differential diagnosis of cryptomenorrhea. Okay, imperforate hymen, I think you all know that. So there it comes as one of the option that this is Gardner duct, or sometimes it comes in with the differential diagnosis with Bartholin cyst. Bartholin duct, when it gets obliterated, it forms a Bartholin cyst. So there you have just need to remember this duct position. This duct is at in the peritoneal cavity, lateral to the upper end of the vagina. It is not down. Okay, imperforate hymen and Bartholin cyst, they both are just at the hymen opening. Okay, these they both are just at the hymen opening or labia majora minora, but this Gardner cyst or Gardner duct is at the upper end of the vagina in the peritoneal cavity. If even if it swells, it creates a swelling in the vagina, but it is very upper, very inner. Okay, so we have to put retractors to see that swelling. Okay, and usually this swelling does not pain, does anything. So if the patient is having any symptom or any disturbance while walking, or anything, any complaints of due to this cyst, then we are going to do incision and drainage. Otherwise no treatment is required, it spontaneously recovers. Okay, now now we will come to the Mullerian anomalies. Before coming to the Mullerian anomalies, let's study what happens normally. Okay, now these are the two Mullerian ducts. Okay, we know that they form fallopian tube, uterus, and upper two-third vagina. The lower one-third vagina is formed by the urogenital sinus. Okay, now the part of the duct, the upper part of the duct, it forms the upper part of the duct forms a fallopian tube and it never fuses. The part of the duct which is forming the uterus, it fuses and it forms a single uterine cavity. See this part. This part of the duct and the part which is forming the upper two-third vagina, it fuses. Okay, this part of the duct, it fuses and it forms a uterus and upper two-third of the vagina. The lower part of the duct, it fuses, but the upper part of the duct, Mullerian duct, didn't fuse and it forms two separate fallopian tubes. Okay, now when these two ducts, two Mullerian duct fuse, their lower part fuse and they form a uterus and they fuse and they form uterus and upper two-third vagina. When they fuse, in the starting, a septa is left behind between them. Okay, which also get resolves later. But after fusion, a septa is left behind, which resolves later. Okay, and the lower one third of the vagina is formed by the urogenital sinus. Now let's see the anomalies. Before studying the anomaly, let us study HSG. What is HSG? HSG, in what we do in HSG, with the help of the Leach-Wilkinson cannula, okay, all these images of Leach-Wilkinson cannula and the other images which will be coming in this session are at my Telegram channel. Okay, so HSG, we're discussing about HSG. In while performing HSG, what we do, we instill a radiopic dye, okay, in the cervix with the help of Leach-Wilkinson cannula. Okay, Leach-Wilkinson cannula is just like this, like a pencil. It's made of steel. So upon the cervix, we fix this cannula. Okay, and from behind we put the dye. Now that dye from the cervix, it goes into the uterus, then it goes into the fallopian tube, and then it come out, the dye come out into the peritoneal cavity. Now basically this dye tell us about the shape of the uterine cavity. What is the shape of the uterine cavity? And number two, it tell us that whether the ducts are patent or not. If the ducts are patent, then only the dye will go into the peritoneal cavity and we will see the spill of that dye. Okay, if the ducts are obstructed, then the dye will not go into the peritoneal cavity and it means the ducts are not patent, right? So basically this is a normal HSG. The normal uterine cavity is triangular in shape and bilateral free spill is present there. Okay, bilateral free spill is present and the uterine cavity is triangular, and in the cervix we have there is, you can say this is the Leach-Wilkinson cannula. Yeah, in the cervix, this is the Leach-Wilkinson cannula we have put here. Okay, now we will studying the female genital tract. We have studied this, right? Now let us study the Mullerian anomalies. Now what are the Mullerian anomalies? Let's see. First of all, there is Mullerian anomaly. Just yeah. First anomaly is uterus diadelphus. What is uterus diadelphus? I told you lower part of the Mullerian duct fuse and they form uterus and cervix, right? And upper two-third vagina. So what happens if this doesn't fuse at all? Then there will be two fallopian tubes and two uterus, two cervix and two upper two-third vagina. And this condition is known as uterus diadelphus. ठीक है, again and again they are asking the question on Mullerian anomaly. So once again I request you just focus here. In uterus diadelphus there will always be two cervix, two uterus and two upper two-third vagina. Okay, so other than two uteruses or two uterine cavities on HSG, we will also get two cervix and two upper two-third vagina, but the lower one-third vagina will be only one. Okay, once again I will focus for you the image of HSG of uterus diadelphus. See, you can see here there are, this is one uterus cavity and this is another uterus cavity. This is a cervix, one cervix, two cervix, this is cervix, this is cervix, this is uterus, another side is another, and this is upper two-third vagina. So what is this HSG? This HSG is of course uterus diadelphus, in which we are seeing two uterus, two cervix and two upper two-third vagina. Okay, now usually in uterus diadelphus patient doesn't have any problem. Okay, everything happens so smoothly. Sometimes when we are doing cesarean or when we are doing any surgery of the laparotomy or any other abdominal surgery, we coincidentally find these findings. Otherwise patient don't come with any complaint. The uterus diadelphus don't create so problems that we have to repair it. Okay, so usually surgical repair is not needed in it. Okay, and infertility, abortions, these are also much less here. Okay, so one questions have come in EPG, whether transverse lie is there in the uterus diadelphus or no. No, you in the uterus diadelphus transverse lie is very uncommon. Why? Just see, already in the uterus, normal uterus, transverse lie is very rare. You know that longitudinal lie is common. Yes, so this uterus diadelphus has got very less transverse diameter, right? So in this uterus diadelphus, any uterus, there are two uterus, in any uterus, if pregnancy occurs, then transverse lie is much less common because the transverse diameter of the uterus is reduced, right? Breach can occur, malpresentations can occur, but transverse lie is very uncommon because already its transverse diameter has reduced, goes to half, right? So that's why, so transverse lie is not there, and usually this anomaly doesn't require any surgery or any treatment. We only find this as coincidental finding. Now the another problem is bicornuate and the septate uterus. During the development of Mullerian duct development or female genital duct development, I told you that when the lower part of the two ducts fuse, then uterus and cervix are formed, and after fusion a septa is left behind which resolves later. Okay, so what happens if this duct don't fuse? Then uterus diadelphus occurs. Okay, now what happens if this you can say uh, if this ducts partially fuse, if this duct Mullerian duct partially fuse, some lower part partially fuse, okay, so there will be cervix will be one because partially fusion of this Mullerian duct is from below to up, down to up. So cervix will be there and some part of the uterus cavity will be fused, but the upper part of the uterus cavity will not be fused. So in total we can say that we will get one upper two-third vagina, we will get one cervix, but the uterine cavity itself will be divided into two parts after some extent. Okay, so that is the case in the bicornuate uterus. And what if the septa which I told you, after fusion septa is left behind, that septa didn't resolve? If that septa didn't resolve, then again the uterus, then again there will be one upper two-third vagina, there will be one cervix, but again the uterus will be divided into two cavities. Okay, so you can see that bicornuate uterus and in septate uterus, both of them, they will have two uterine cavities, so their HSG will be somewhat similar, right? Two uterine cavities, one cervix, one upper two-third vagina, but the uterus diadelphus, there are clearly two cervix and two upper two-third vagina. But in the case of the bicornuate uterus, see, both are having one cervix, one upper two-third vagina, right? See, and the two there are two uterine cavities. Now, how to differentiate on HSG? Here we will see, this is the bicornuate uterus. Are you appreciating it? This is a bicornuate uterus. Here you see this diagram, you see there is one cervix, right? Don't focus on this, focus on this. There is one cervix, yeah, you just focus on this diagram. So you can see that there is one cervix, right? There is one cervix and there are two uterine cavity, and this one is a septate uterus. Okay, so you can see that there is one cervix and the uterine cavity is divided into two. So what the main difference is there? That here the between the two cavities there is a uterine wall. In the bicornuate uterus, between the two cavities there is a uterine wall. See, basically it is like this, right? Are you getting? But what is septate uterus? Septate uterus is, what is septate uterus? Yes, in the septate uterus between the two cavities, yes, so in the septate uterus between the two cavities there is not uterine wall, there is a septa. Okay, there is a septa in between. This muscular uterine wall is not there. Okay, so what happens, due to which what happens, the angle between the in the in this because there is no uterine wall in the septate uterus, in the septate uterus the angle between these two cavities, see, this is one cavity, this is one cavity and this is two. So the angle between the two cavities is usually acute. Okay, and the angle between the two cavities in the case of bicornuate where there was uterine wall in between is obtuse, because uterine wall is there in between, right? Right, so the angle is obtuse, the angle is more because uterine wall will occupy some space, right? And whereas in septate uterus, as septa is thin and there is not uterine wall, so it will occupy less space, so angle is acute. So the treatment of biconvate uterus is metroplasty, and the treatment of septate uterus is septal resection. Okay, so this has come in NEET PG 22. This question has come, so high chances are there it can be repeated, it can come in your exam. So if you find that the angle between the two uterine cavity is acute, then it is septate. And if the angle between the two uterine cavity is obtuse or more than 90 degree, then it is uh, biconvate. And there, because uterine wall is coming inside, then there we have to do metroplasty. Metro means uterus wall, myometrium. Okay, so there we have to do metroplasty. We have to cut that wall and then make the uterus one cavity. And in the case of the septate uterus, as there is no uterine wall in between, then we have to do septal resection, not metroplasty. Here we are not doing anything with the uterine wall. Here we are doing with everything with the septa, and it is very easy surgery. Septal resection is a very easy surgery. All of those who you will become gynae resident, you will able to perform it in the first year itself. Okay, and metroplasty is a very difficult surgery. We were able to perform in second or third year. Okay, so you can see that septal resection is the most easy to repair, and we quite often repair it by hysteroscopic septal resection. Okay. Okay, so what happens now? We know that uterus is formed from two Mullerian duct when the lower part of the Mullerian duct diffused, right? So what if the one duct didn't grow and only one duct grows? Then only what if one duct grows and one duct didn't grow? So then we will our uterus will be of the half size, right? And it will be tilted to one side only. Okay, so that uterus is known as unicornate uterus, and here the tilted one-sided uterine cavity is there. This is the HSG image, and I know you all know this image. Okay, so shifting our topic to primary amenorrhea, one question was left. When you are going to do repair of biseptate and uh, bicornuate uterus, when you are going to repair those uteruses, surgically repair आप कब करोगे? You will only do when the lady presents with when the female presents with multiple abortion or habitual abortion or recurrent pregnancy loss. Okay, because sometimes this bicornuate uterus and septate uterus, they are very mild variety. Only in biconvate uterus, only small fusion is not there. Okay, rest all the ducts have fused. And in septate uterus, only some part of the septa is not resolved. So if they are the mild variety, we need not to do any surgery. They are not going to create any problem. So we are going to repair these anomalies only and only if they cause habitual abortions. And these anomalies, they don't interfere with fertility. Pregnancies do occur, but if these anomalies are of severe varieties, then abortion occurs. Okay, okay, let's now go to the primary amenorrhea. Okay, here first we need to revise the basic menstrual cycle. Okay, let's see what is the basic menstrual cycle. So here there is the basic menstrual cycle. Okay, so first of all, you know that when a female reaches puberty, then there is activation of HPO axis. H stands for hypothalamus. When a female reaches the puberty, hypothalamus releases gonadotropin releasing hormone, and that gonadotropin releasing hormone, it acts on pituitary and it releases the gonadotropins. What are the gonadotropins? FSH and LH, right? So first the pituitary releases FSH. This FSH go and act on the follicle which is inside the ovary. Okay, so this is a follicle which is inside the ovary, and this follicle now grows, increase in size. And what is the function of this, what hormones this follicle synthesize? This ovarian follicle is synthesize estrogen, and this estrogen then acts on the uterus. This is uterus. Okay, and this make the endometrium proliferatory. Okay, and it makes the endometrium proliferate. Okay, and now when the level of the estrogen is more than 200 picogram, when the level of the estrogen is more than 200 picogram in the blood, then it gives negative feedback. Only when the level is more than 200, then estrogen level more than 200 is there in the blood, then the hypothalamus get the negative feedback. Then the hypothalamus switch off. Okay, and the switch gets on for the LH. Okay, then the LH is released. See, I have written this 200 in red, and similarly I have shown this in red color. See, this is, yes, so this, when it estrogen level is more than 200, then the hypothalamus gets a negative feedback, and the switch gets off for the estrogen, and the switch gets on for the LH. Now LH is released, and you know that LH surge causes ovulation. LH surge causes ovulation. Now ovulation will occur and corpus luteum will be formed. Now the corpus luteum life is fixed, right, 10 to 12 days. Now after the corpus luteum synthesizes progesterone, and this progesterone makes the endometrium. What is the function of the progesterone? It stabilizes the endometrium, and it stabilizes the endometrium, and it makes the endometrium secretory. Now you see, red secretions are there. Now it don't lets the endometrium to proliferate. Now it makes this endometrium secretory, right? And soon after the corpus luteum dies, and then what happens? When the corpus luteum dies, the progesterone withdrawal occur, and due to the progesterone withdrawal, periods come. This is a normal menstrual cycle. Now we were studying primary amenorrhea. So this all happens at puberty, and this cycle keeps on going. Okay, so when the LH progesterone falls, progesterone level falls, then again the FSH rises up and next cycle starts. Now we were studying the primary amenorrhea, right? Now what if the hypothalamus gets failed? Now what will happen if the hypothalamus gets failed? What will happen if the hypothalamus get failed? If the hypothalamus will get failed, then this whole HPO axis will not start, right? The GnRH will not be secreted. There will be no FSH-LH. There will be no estrogen and progesterone. So this condition is known as hypogonadotropic, because gonadotropins are less. Hypogonadotropic. Hypogonadism. Even the gonads, the ovaries, they are not functioning. This condition is known as hypogonadotropic hypogonadism. So if the hypothalamus fails or is not active due to any problem, then what will happen? The gonadotropin releasing hormone will be less, FSH, LH will be less, and estrogen and progesterone will also be low levels. So this syndrome is known as Kallmann syndrome, and this is accompanied by anosmia. Here one main clinical symptom is there. There is anosmia. The patient, the girl cannot smell. Okay. Now when there is no estrogen and progesterone, there will be no menses in spite of the uterus being there. Okay, so there will be no menses. Okay, and this estrogen is also responsible for the secondary sexual characteristic. Okay, now when there is no estrogen, then there will be no secondary sexual characteristic also. So this Kallman syndrome female will present to in the OPD with absent of secondary sexual characteristic and absence of menses. And one typical complaint this female will give anosmia. Okay, question has came on this in NEET PG 22. High chances are there question will come to you also. So in this Kallman syndrome, you have only need to remember the hypothalamus gets filled, GnRH is less, so FSH, LH, gonadotropins are less, and estrogen, progesterone are also at a low level. And so it is a condition of hypogonadotropic hypogonadism. And here the patient will not have the secondary sexual characteristic, and the patient will not have any menses. Okay, I hope it's clear. Now, what happened if the hypothalamus was functioning and the ovaries get filled? What will happen? So now gonadotropins will be there, FSH, LH will be there, but as the ovaries have failed, are not functioning, or if they are present, they are not functioning, then it means there will be no estrogen and progesterone. There will be no estrogen and progesterone. Now, because you saw that in the menstrual cycle, estrogen was giving the feedback response to the hypothalamus to negative feedback response. When was the hypothalamus was getting negative feedback response? When estrogen level was more than 200 picogram per ml, right? We discussed that. So when that level, that level will never be achieved because ovaries they have failed. So the gonadotropin releasing hormone and the FSH LH will be much high. So what is the stage known as? Hypergonadotropic hypogonadism. The before stage was hypogonadotropic. The hypothalamic failure was hypogonadotropic hypogonadism. This stage is hypergonadotropic hypogonadism because there is no estrogen, so no one is telling the hypothalamus to shut down. So hypothalamus is working effortlessly. Okay, this hypothalamus keeps on releasing gonadotropin releasing hormone. So gonadotropin releasing hormone and FSH, LH are in much high amount. Okay, so there are two hormone changes in ovarian failure. First of all, there will be low estrogen and progesterone, and there will be much high gonadotropin releasing hormone and FSH, LH. Why it will be hypergonadotropic? Because the ovary estrogen was giving the negative feedback. Due to the lack of that negative feedback, the gonadotropins, the FSH, LH are much high. Okay, so now already discussed that secondary sexual characteristics are due to estrogen. So again, this girl will not have any secondary sexual characteristic. This girl will have no breast, no peak of the height, and no axillary and pubic hair, and of course this girl will not have any menses. Okay, so now you have learned about two cases of primary amenorrhea. Number one was Kallman syndrome. Kallman syndrome, there was a hypothalamic failure and all the hormones were at low level, even the gonadotropins and even the estrogen progesterone. There also the girl present with loss of secondary sexual characteristic and loss of menses. with primary amenorrhea. And in this ovarian failure also the girl is presenting with somewhat similar, but there is hypergonadotropism. So you all know that one of the case of the ovarian failure is a Turner syndrome. So we should all know the features of Turner syndrome. So first five features are the features which we see when we see the patient of Turner syndrome. Okay, so let's see the patient of Turner syndrome. So this is a patient of Turner syndrome. Okay, so here I would like to tell you that symptoms. First of all, there is short height. Okay, so it's a short height. They are about 3 to 4 feet because estrogen is responsible for the height, and these people they have less estrogen. Then there is microgynethia. This jawline is very small. Then there is webbed neck. Are you able to appreciate? Due to the lymphedema, there is webbed neck. The ears they are lost at. These ears should be here, but they are not here. They are quite low set ears, and there is sensory neural hearing loss. So these are the five features. They keep on asking you about the features of Turner syndrome. These five features should be on your tips. Okay, number one is short stature, number two is webbed height is short, webbed neck, and due to lymphedema, the low set ears, the sensory neural hearing loss, and the microgynethia means the jawline is very small face. The heart anomaly which we usually see in the Turner syndrome is coarctation of aorta, and we also get renal anomalies. Other than that, we get autoimmune disorder, and this all patients they also suffer from high blood pressure. Okay, so all this thing you have to cramp. Okay, mainly the heart and the kidney system is involved. Okay, so mainly the heart coarctation of aorta is there, and hypertension is there, and renal anomalies and autoimmune disorder is there. So nine features it should be on your tip. They keep on asking. Above all, these females they never suffer from mental retardation. They have all these complexities in their life, and I personally know some of the Turner syndrome females. These are quite confident girls. Okay, so let's see how we are going to help this Turner syndrome patients. Not much we can do, only is that because these patients they have low estrogen and progesterone, so we are going to give this patient estrogen and progesterone. This will help the uterus to grow, and if they want to conceive, as their eggs are not working, so they need to get donor eggs, and they need to get IVF done. Okay, so what are investigations we will go. So first of all, these girls they don't suffer from mental retardation. Again and again I'm telling you, the ultrasound shows bilateral streak gonads, and if we want to confirm our diagnosis, we have to confirm it by karyotype. Okay, and the most common the most common gonadal dysgenesis, in where the gonads they don't work. Here I want to tell you the cause of primary amenorrhea. Most common cause of primary amenorrhea is gonadal dysgenesis, and one of the cause of gonadal dysgenesis is Turner syndrome. Okay, and one of the cause of gonadal dysgenesis is Turner syndrome. Okay, so if gonadal dysgenesis is mentioned in the list of the most common cause of primary amenorrhea, you are going to mark gonadal dysgenesis, and if only Turner syndrome is there, then you are going to mark most common causes Turner syndrome. Okay, in my this chanting session I have missed cryptomenorrhea intentionally, because you all know this topic very nicely. There was more than 90% of the questions they were correct from the cryptomenorrhea. If anyone is having any problem in cryptomenorrhea, do read it. Okay, okay, now let's go to the next slide. We saw that the hypothalamus failed. We saw that ovaries failed. What will happen if the uterus will fail? If the uterus fail or the uterus are absent? Okay, so if the uterus fail or if the uterus are absent, and then the syndrome is MRKH, Mullerian or Rocket-Kensky Kuster-Hauser syndrome. Okay, so this in this syndrome, the Mullerian duct were forming which all structures? Can you tell me? Uh, Fallopian tubes, uterus, cervix and vagina, upper two-third vagina. So because Mullerian duct is not growing, so all these structures they will be absent in these females, but ovaries are present, hypothalamus is present. So on puberty, your hypothalamus will release gonadotropin releasing hormone, and then FSH will be released. Then ovaries are functioning, so estrogen will be released, and that estrogen will cause negative feedback also. So every hormonal workup will be normal. So estrogen, progesterone, so all the hormones are normal in the case of the uterus failure. Okay, but these they are not having the periods. Why they are not having the periods? They are not having the periods because in these patients there is no uterus. Mullerian duct didn't grow. So the another name for MRKH syndrome is Mullerian HNSS. Okay, so this patient will come to us as estrogen and progesterone they both are normal. So this patient will have a normal secondary sexual characteristic, right? So these patients they will not come to us with loss of secondary sexual characteristic or no breast. This patient will have a breast. Okay, and these patient will come to us with amenorrhea. Okay, now what is the next step? What we will do? So we will examine this patient. The patients which are coming to us with loss with the secondary sexual characteristics in primary amenorrhea, we are going to examine that patient, and if we see that there is no cryptomenorrhea, then what we are going to do? We are going to see whether their uterus is not there or not. So usually in this patient we will see the blind vagina, because I told you in initially only urogenital sinus, it forms the urogenital sinus forms the lower one third of vagina. So a small vagina will be there. So we can't do PV because through that small vagina. So per rectally we are going to see whether the uterus is there or not. So then we will get the ultrasound done. So most of the time it is asked what is the next step. So karyotype is not the next step. Next step is on examination we got in this patient that there was no uterus. On per rectum we found that there was no uterus. So now we are going to get the ultrasound done to confirm the finding. Okay, now if we got no uterus, then our finding is Mullerian agenesis or androgen insensitivity syndrome. We are going to study that, and then we are going to confirm it by karyotype. So what will be the karyotype of these patient? The karyotype of these patient will be XX. Okay, the another cause, another characteristic, another condition in which uterus is absent and there is secondary sexual characteristic are present is the androgen insensitivity syndrome. So soon we will discuss that, and then we'll know how we will differentiate it clinically. Okay, so how we are going to treat this? So what we are, how we are going to treat this patient? How we are going to help this patient? So of course, the uterus is not there. So these girls they can't conceive. So okay, uterus transplantation is happening in medical science in some hospitals, but still they are not affordable to all. So here either we will tell the patients to get their uterus transplanted, or if they can't afford those surgeries, then what we will do, we will no need to give hormones in these patients. No need to give hormones in these patients. Okay, and we will and ovary is functioning. These patients they do have their own eggs, so we will get the surrogacy. Okay, Surrogacy is a treatment. And how more we can help, because these are females, so they have to pursue their sexual life. So we will do vaginoplasty. And this vaginoplasty, because with such a small vagina, that female will not be able to do intercourse, so we will get the vaginoplasty done. The most successful vaginoplasty is McIndoe vaginoplasty, and it is done just before the marriage or after the marriage. So when intercourse starts, then that vaginoplasty remain functional. Okay. Okay. Now the another case is of primary amenorrhea is male pseudo hermaphrodite. So let's discuss what the hermaphrodite means. So hermaphrodite or intersex means the persons in whom the male and female both features are present. To whom we say intersex. Intersex means the male and female both features are present. So what do we understand when we say true hermaphrodite? It means in their gonads, ovarian and testicular tissue both are present. Ovarian and testicular tissue both are present. In the gonads itself, both type of tissues they are present, then it is known as true hermaphrodite. And what is pseudo hermaphrodite? Pseudo hermaphrodite means in those type of human beings in which the gonads are either testes or ovaries. Okay, gonads are either testes or ovaries, but their phenotype, their external genitalia is different, their external appearance is different. Okay, so what we will say it male pseudo hermaphrodite if their genotype is XY, and of course now we know when the genotype is XY the gonads are testes, but in spite of having the XY genotype and testes, their phenotype is female. Okay, okay, they look like female, they behave like female. Okay, and female pseudo hermaphrodite. Female pseudo hermaphrodite, what do we understand with female pseudo hermaphrodite? Their genotype is XX, their genotype is XX, and they have ovaries. Okay, only ovaries, no testicular tissue in the gonads, only ovaries, and the genotype is XX. But due to some problem, their phenotype has become the male. Okay, so originally they are known as pseudo hermaphrodite because originally they were male. Pseudo hermaphrodite because originally they were male, but because their phenotype is different, they have become the hermaphrodite. Okay, so male hermaphrodite is one in which the gonads are testes and in which the genotype is XY, but the phenotype is female. Now you know what is male pseudo hermaphrodite, but this male pseudo hermaphrodite is looking like a female. It's is having a total external appearance, secondary sexual characteristic, and the external genitalia that of the female. Now this patient can come to us with primary amenorrhea. Yes, it will come, and then it is known as a, then the question will come like female comes with primary amenorrhea, right? Yes, because as they are males, originally they are males, then these will don't they will not have the uterus. Okay, let's study. So as we have already read this, let's now in this slide we are studying the development of the external genitalia. Okay, so you know that when there is XY chromosome, then testes are formed. Then these testes, Leydig cell, they synthesize androgen. Then the Wolffian duct grows into male internal genitalia, and the Sertoli cells they secrete MIS, and then the Mullerian duct regresses. Okay, now these testes, these androgens, they act on Wolffian duct, and the Wolffian duct grows, and these androgens, they also act on genital tubercle and swelling, and they form male external genitalia. Okay. Okay, and now these androgens, they also makes the male secondary sexual characteristic. Now what if these androgens are formed, but these androgen receptors, by which the by which all the functioning was occurring, is not occurring. Okay, by which all the androgens work by the receptors, they act on the androgen receptors. Now these receptors, they are not sensitive to androgen. Then the all this functioning of androgen, that formation of male internal genitalia, formation of male external genitalia, will not be there, because these androgen receptors are at fault. The secondary sexual characteristic will not be there, right? So what will happen now? What is the androgen insensitivity syndrome genotype? It is always XY. The gonads, they will be testes, because now there were no androgen. What will be the phenotype? The phenotype will be, the external genitalia will be that of the female. The external genitalia will be female, because in the absence of androgen, the genital tubercle and swellings, they form. In the absence of androgens, these genital tubercle and swelling, they form female external genitalia. So now there will be female external genitalia. What about secondary sexual characteristic? Do this XY male will have secondary sexual characteristic of male? No, because all the secondary sexual characteristic of males are due to androgens. The androgen receptors are fault, so they will not have any secondary sexual characteristic of male. But do this will have the secondary sexual characteristic of female? Yes, because the androgen gets converted into estrogen by the help of enzyme, and that estrogen can act. And because in the males there is lot of androgens, right? So now this time, much more estrogen will be formed from the androgen, and a grade higher tanner grade breast will be formed. Okay. Okay, now we will hear that the phenotype will that be of the female. Secondary sexual characteristic will also be of female. Now see, if the patient of Mullerian agenesis come to us, and the patient of androgen insensitivity syndrome come to us, we don't know what is the karyotype, of course, in the OPD. We know both these patients are phenotypically female, both of these are secondary sexual characteristic of female. Then how we will differentiate between these two clinically? Okay, I will tell you. Because in the patients of androgen insensitivity or testicular feminizing syndrome, they don't have the androgen receptors, so the axillary and pubic hairs will be absent in the patient of androgen insensitivity syndrome. And but in the patient of Mullerian agenesis, they will be present. Okay, all pubertal females, they have the axillary hair and pubertal hair, but here their androgen receptors are not working in the whole body. So they in the testicular feminizing syndrome or androgen insensitivity syndrome, the axillary and pubic hair, they will be absent. Okay, so the one written in the green color is very important. Okay, So how we will help this androgen insensitivity syndrome patients? First of all, we know that the gonads that they are having is testes, right? So we will do the gonadectomy, and we will do this gonadectomy in the on the puberty, because their androgens were making that breast of the patient of androgen insensitivity syndrome. So we want कि at least वो पूरी female तो बन जाए, right? Right? Okay. So we will also do vaginoplasty, because now this XY genotype androgen insensitivity syndrome will live a life of a female. Okay. So we will do a vaginoplasty so that his partner can do intercourse. So, and again, that vaginoplasty is done just before or just after marriage. And now how these can conceive? Now they don't have their ovaries, so they will need a donor egg and surrogacy. Okay, so this is how they can get their child. So we saw that in androgen insensitivity syndrome, androgens were produced, but the androgen receptors were faulty, and that is why the whole XY genotype changed into female, and the secondary sexual characteristic also changed into female. What if due to any other reason, the again this same problem came, not due to receptor? For example, are there any other reasons? Yes, there are. They are now they are being asked in the exam. Last time they have asked in INS set May 22, or I think in the December November exam. See what are the reasons. 5 alpha reductase deficiency. Now you know 5 alpha reductase is an enzyme which changes the testosterone into 5 dihydrotestosterone, right? 5 alpha reductase changes the testosterone into dihydrotestosterone, and the active form of the testosterone is dihydrotestosterone. Now if this enzyme is not there, so again these androgens can't function, right? Again this androgens can't function. Again it will be a same story, right? Wolffian duct will regress, Mullerian duct will also regress, uterus will also be absent because MIH was there. Again, external genitalia will be of female, and secondary sexual characteristic will be of female, right? So again the same story, but now here the fault is not in the androgen receptors insensitivity, but the fault is in the 5 alpha reductase deficiency. Okay, now what if their Leydig cells which were synthesizing the androgens, they got undergo aplasia? Then there will be no testosterone, again there will be no androgens, so again there will be no male external genitalia, and there will be a female external genitalia. So these are some other reasons where androgens is not functional or androgen is not there. So these patients, they will also come up with male pseudohermaphrodite case. So in total we studied four type of patients. Okay, once again I would like to tell you, we studied four type of patients of primary amenorrhea. Okay, one in which along with primary amenorrhea, the yes secondary sexual characteristic was absent, the one in which there was hypothalamic failure Kalman syndrome. Okay, the another patient was primary amenorrhea. Again here secondary sexual characteristic were absent. This was a patient of ovarian dysgenesis or ovarian failure. Okay, so the first one was the Kalman. So here there was hypogonadotropic hypogonadism. So this is what chanting is going on. Speak out with me. Hypogonadotropic hypogonadism. But in the patient of ovarian failure, there will be hypergonadotropic hypogonadism. Okay. And in the case of another case of primary amenorrhea, we studied in which there was secondary sexual characteristic were present, but the uterus was absent. So that was a case of Mullerian agenesis. The another case, similar case, but the patient was male pseudo hermaphrodite, and there how we will differentiate the third and fourth case, androgen insensitivity syndrome and Mullerian agenesis, that the axillary hairs are absent in the case of the androgen insensitivity, but they are present in case of the Mullerian agenesis. Okay. Now let us study secondary amenorrhea. Okay. Again we will study in the similar way. Okay. What happens when now what is happening in secondary amenorrhea? Once in the puberty the girl has achieved menarche, but again it stopped. Okay. So secondary amenorrhea, you have to do UPT. In both primary amenorrhea and secondary amenorrhea, you have to first rule out the pregnancy, because these days we are getting the patient 13 14 years patient we are getting with pregnancy. Okay. So in my 10 years of practice I have diagnosed 3 4 patients UPT positive at the age of 13 14 years. Okay. So patient will come to you. So in the case of primary amenorrhea and secondary amenorrhea, because you know that pregnancy is one of the reason of amenorrhea, so you are going to do UPT. Okay, rule out pregnancy first. Okay. So now we have, once UPT has come negative, now we will go to the another causes. Again we will see HPO excess. What will happen when hypothalamus will fail? How hypothalamus can fail? Now this time it will not be Kalman, because Kalman will not present with secondary amenorrhea. So this time the reason for hypothalamus failure is anorexia nervosa. Okay. All those slim girls, right, who exercise a lot and don't eat anything, their hypothalamus get fails. So they suffer from anorexia nervosa. The FSH and LH both are decreased, right, and estrogen is also decreased. The same hypogonadism. Okay. And same happen when there is prolactinoma, when prolactin is excess, hyperprolactin is there, right. So it also suppresses gonadotropin releasing hormone or hypothalamus. Okay. In the similar way, thyroid hormones also influence the gonadotropins. Okay. So these are the 3 reasons in which the hypothalamus is can be affected, and there can be secondary amenorrhea: anorexia nervosa, prolactin, and thyroid. Okay. So in all of these conditions, the hypothalamus gets affected. There is decrease in gonadotropin releasing hormone, and there is decrease in estrogen. Okay. And patient suffers from amenorrhea. So hormonal workup you know now nicely. What happens if pituitary fail? Pituitary fails in Sheehan syndrome, where there is, due to the PPH, the pituitary undergoes hypoxia, and that is known as Sheehan syndrome. What will happen in Sheehan syndrome? All the pituitary hormones will not be released. Thyroid, adrenocorticotropins, then adrenocorticotropin, and then thyroid hormones, gonad, FSH, LH, and all the other hormones, they will TSH. All the pituitary will shut down. Pituitary failed in Sheehan syndrome, and it fails due to PPH. So lactation will also not be there. Okay. So this is the case of Sheehan syndrome. Again in Sheehan syndrome, FSH, LH will be less, and estrogen will also be less, right. Now what happens if ovary fail? When ovary fail, at menopause or premature ovarian failure. Okay. Now again you know that it will be a hypergonadotropic hypogonadism condition, and the patient ovaries dysfunction also in PCOS. What happened in PCOS? LH is increased and FSH is decreased, right? We will study detail in the PCOS. So either the ovaries fail, they stop functioning. That happens during menopause or premature ovarian failure, and sometimes ovary they don't function properly, as in the case of PCOS. So in both the cases, the yes. In the case of ovarian failure, menopause, the patient will have FSH, LH high in amount and estrogen decrease in the amount. What happens if the uterus becomes non-functional? If the uterus is not able to, the endometrium is present but it is not able to proliferate, so then it is known as Asherman syndrome. Here the patient gives you a history of DNC, and the anterior and posterior wall of the uterus, they got fused. Now because they have fused, there is adhesion between the anterior and posterior wall, they have fused. Now endometrium cannot proliferate, so due to the adhesions, tight adhesions between the anterior and posterior wall, now the endometrium cannot proliferate. So now this patient will have all its hormonal levels normal. Okay. Okay, because I have discussed all these hormones in detail in primary amenorrhea, so I'm not discussing it here. Once again, I would like to tell you the condition in which hypothalamus gonadotropin releasing hormone is blocked is anorexia nervosa, prolactinoma, and thyroid hormone problems. Okay, there the patient suffer with hypogonadotropic hypogonadism. In pituitary failure also the hormones are of the same type, and then there is Sheehan, pituitary fails in the case of Sheehan syndrome secondary to PPH. Okay, and ovary fail due to premature ovarian failure or menopause, and ovarian dysfunction is there in the case of PCOS. We will study PCOS in detail. And Asherman syndrome is the uterus endometrium cannot proliferate because due to the previous history of DNC, the anterior and posterior wall has fused. Now the endometrium cannot proliferate, so again the patient will have amenorrhea. Okay, Asherman syndrome patient usually suffers from hypomenorrhea, but after some time they suffer from amenorrhea also. Okay. HSG image of the hypomenorrhea is already done on my Telegram channel. So all of those who don't know the HSG image of the Asherman syndrome can visit my Telegram channel and get more images again. So now there is one is estrogen progesterone test and one is progesterone challenge test. In PCOS, the endometrium proliferates, but there is no but there is no but there is no uh, ovulation, so there is no corpus luteum and there is no progesterone phase, so LH keeps on increasing. So but in the PCOS patient, the endometrium has proliferated but it hasn't gone into the luteinizing phase, the second phase, the progesterone phase. Okay, so here whenever we will give the patient external progesterone, this patient will bleed. Okay, so PCOS patient bleeds when we give external progesterone, so that is known as progesterone challenge test. So a PCOS patient bleeds when we give a progesterone challenge test. So we also give estrogen and progesterone challenge test. So all the case of hypothalamic failure, pituitary failure and ovarian failure, all of these patients, they will bleed, or bleeding or periods will come to them when we will give estrogen and progesterone in these patients, because uterus is functional in the case of hypothalamus pituitary ovarian failure, right? Only the hormone production was not there, but uterus was functional. So when we have to differentiate that uterus is for example, a patient of Eshelman syndrome comes and patient says, I can't afford such FSH, LH and estrogen test. Is there any another method? Then what we will do, we will give that patient estrogen and progesterone. Okay? And if that patient doesn't bleed, it will not bleed, because in the Asherman syndrome the uterus is at fault. So uterus is not going to bleed at all in the case of Asherman syndrome, because endometrium cannot proliferate. But in the case of hypothalamus pituitary and ovarian failure, in all these cases, the on giving estrogen and progesterone challenges, the patient will get periods, because there the estrogen and progesterone were decreased, right? But in the case of the uterus defects, the hormones were normal, but there was defect in the uterus, so that defect cannot be get okay by estrogen and progesterone. So here the patient will not bleed by giving estrogen and progesterone challenge test also. But in the case of PCOS, only progesterone will help us to get that patient bleed. So these are known as progesterone, estrogen, progesterone and progesterone challenge test. So small about the progesterone, female pseudohermaphrodite or adrenal hyperplasia. Okay, so female pseudohermaphrodite means the genotype is and the gonadal tissue is that of female. The genotype is XX and the gonads are ovaries, but the external genitalia is that of the male. How come the external genitalia is male? You all know that if the androgens act on the genital tubercle and swelling, then the external genitalia is that of the male. Now if in some problem of that XX genotype patient, due to some problem the androgens were excess, then of course that genitalia will become male if there was excess production. And when there is excess production, the excess production of androgens which converts the genitalia into male is in the adrenal hyperplasia. It can be congenital or it can be juvenile onset. Okay, so normal, what is a normal adrenal gland functioning? Just see here, as there was HPO excess, in the similar way there is a hypothalamus pituitary adrenal excess. Okay, so adrenocorticotropic releasing hormone is released from hypothalamus, and then further pituitary releases adrenocorticotropic hormone which acts on the adrenal cortex. So what is the function of adrenal cortex? The adrenal cortex changes the cholesterol into aldosterone, cortisol and androgens, right? The Don't see these figures, blue figures, just see here. The cholesterol is changed into aldosterone, cortisol and androgens by the adrenal cortex. Now you all know, you are very good students, what is the function of aldosterone, cortisol and androgens. Okay, now these aldosterone and cortisol, they give negative feedback to hypothalamus, but these androgens, they don't give the negative feedback to hypothalamus. Now let's see what happens in the adrenal cortex and how this aldosterone and cortisol and androgens are formed. Cholesterol changes into pregnenolone. Okay, this pregnenolone is acted upon by 3-beta hydroxysteroidal dehydrogenase and progesterone is formed, and this progesterone is acted by 11 and 21 hydroxylase, and then aldosterone is formed. Okay, and when this progesterone is acted by 17 hydroxylase, then 17 hydroxy progesterone is formed, and this 17 hydroxy progesterone is acted upon by the very same enzymes 11 hydroxylase and 21 hydroxylase, and then cortisone is formed. Okay, and then this 17 hydroxyprogesterone gets changed into the androgens. So this is a pathway by which the cholesterol forms aldosterone, cortisone, and androgens. Now what happens is that this 21 hydroxylase enzyme deficiency if occurs, then aldosterone and cortisone will not be formed. Okay, only and only androgens will form. Okay, now see, the aldosterone and cortisone, when they will not be formed, then only and only androgens will be formed. Then there will be no one to give negative feedback. So hypothalamus will keep on functioning. As a result, there will be adrenal hyperplasia. So and if this happens congenitally, it means that there is congenitally adrenal hyperplasia. So in what will happen in congenital adrenal hyperplasia, there will be excess of androgens, and there is decrease of aldosterone and decrease of cortisone. So what is the function of aldosterone and cortisone? Sodium and water retention is a function of aldosterone and cortisone. Yes. So okay. So what will increase in the blood? Aldosterone and cortisone will decrease. What will increase? Androgen will increase, and the 17 hydroxyprogesterone will also increase. This whole progesterone, pregnenolone, and 17 hydroxyprogesterone and androgens, this whole pathway will increase because there was no negative feedback. This negative feedback was due to aldosterone and cortisol. Now they are lesser in amount, so there is no one to give negative feedback. So this whole pathway becomes hyperactive in absence of negative feedback. So there is adrenal hyperplasia and there is excess of 17 hydroxyprogesterone. All this is asked. Okay, why there is 21 hydroxylase deficiency? Why there is 21 hydroxylase? What happens when there is 21 hydroxylase deficiency? Then no aldosterone and no cortisone is formed, and there is adrenal hyperplasia due to the lack of the negative feedback system by the aldosterone and cortisone, deficient aldosterone and cortisone. So there is excess of androgens, and these excess of androgens in the case of congenital adrenal hyperplasia, they don't let the female external genitalia form. They make the female, instead of female external genitalia, the male external genitalia is formed. Okay, so treatment of this is cortisone. Okay, and if we want to treat this intrauterine during the time of the genital development, we want that proper genitalia to be formed, then we have to give the dexamethasone is a drug of choice. But if we want to give it in an adult stage, then cortisone is the treatment of choice. Okay, so if this problem occurs in a juvenile onset, then what happens in a juvenile, then these patients, they come with primary amenorrhea and clitoromegaly, because female genitalia is already being formed in the intrauterine line. Then they comes with hyperandrogenism features, sudden hyperandrogenism and clitoromegaly. Okay, and primary amenorrhea. Okay, so male pseudohermaphrodite can also come with primary amenorrhea, and female pseudohermaphrodite with clitoromegaly can also come to us with primary amenorrhea. Okay, and the treatment is cortisone, and the best prognosis is with, and then after giving the cortisone or in the intrauterine life, after giving dexamethasone, everything happens smoothly. Okay. Now let us study contraception. Our intersex topic is over. So you all know the two main contraceptions are combined oral contraceptive pills and And properties. So first, let's see combined oral contraceptive pills. Lot of you are doing mistakes in the mechanism of action of combined oral contraceptive pills. Why, I don't know, but please clear this thing. This is very important. Just it's very simple. See, when we give orally estrogen and progesterone, that estrogen and progesterone act on the hypothalamus, and it blocks the, but due to the negative feedback, it blocks the hypothalamus HPO axis. So the natural HPO axis, it gets blocked. Okay, so now the whole body is on the external estrogen and progesterone which we are eating, because the body own natural estrogen and progesterone factory कौन सी होती है estrogen and progesterone factory? HPO axis, वो तो हमने ब्लॉक कर दिए ओरल ईस्ट्रोजन और प्रोजेस्टेरॉन देके. अब पूरी की पूरी बॉडी डिपेंडेंट है एक्सटर्नल ईस्ट्रोजन और प्रोजेस्टेरॉन पे. ठीक है, तो आप क्या करेंगे, अब इनका एक्शन देखते हैं. जो हम द अमाउंट ऑफ ईस्ट्रोजन विच वी आर गिविंग इन द कंबाइंड ओरल कॉन्ट्रासेप्टिव पिल्स, इट इज मच मच लोअर लेवल than the amount which we give in which is produced normally in the body. Once again, one mechanism of action is suppression of HPO axis. So no FSH is formed. When no FSH is formed, then no follicle will get stimulated, and when there is no LH, then no ovulation will occur. Is it okay? So how the suppression of HPO axis gives the contraceptive effect? Because when HPO axis gets suppressed by the estrogen and progesterone, preventing the negative feedback, then there will be no FSH. When there is no FSH, no follicle will get stimulated, and when there is no LH, no LH surge, ovulation will also be not there. This much is okay. Now the body's own estrogen progesterone production has been blocked by the suppression of HPO axis. Now the body is dependent on the oral estrogen and progesterone which we are giving in the combined oral contraceptive pill. And this oral combined oral contraceptive pills, estrogen is much lower in amount as compared to the body's natural estrogen. So all the actions of the progesterone come. Okay, so let us see what are the actions of less estrogen and normal progesterone on the uterus. You know that estrogen makes the endometrium proliferatory. So what will happen here? The estrogen will proliferate because small amount of estrogen is there. Endometrium will proliferate, but it will be very thin, as thin that it will not be able to undergo it will not allow the endometrium is very thin, so it will not allow the fetus to implant. Thinning of endometrium, tube's motility will be decreased because there is increased progesterone action is getting dominant, estrogen is less, progesterone action dominates. So due to the progesterone dominating action, tube's motility gets decreased, and cervical mucus, it also gets thick, again due to the progesterone dominancy. Due to progesterone dominancy, the uterus endometrium gets thin, tubal motility also gets decreased. Uterus endometrium, it gets thin due to the progesterone dominancy. The tubal motility, it gets decreased, and cervical mucus, it becomes thick. Okay, now next important thing about combined oral contraceptive pill is its contraindications. Okay, its contraindication. Okay, estrogen, and when is combined oral contraceptive pills contraindicated? See, the estrogen they have one important side effect, that they have increased coagulation tendency. ठीक Okay, they increase the coagulation tendency of the body. So all those person who have increased coagulation tendency, we will not give this estrogen containing combined oral contraceptive pills. So who all have increased coagulation tendency? By virtue triads, we know in the persons in which endothelium is dysfunctions. Endothelium dysfunction is there. Due to the smoking, there is endothelial dysfunction. Due to the hypertension, there is endothelial dysfunction. Due to diabetes mellitus, vasculopathy, there is endothelial dysfunction. And in migraine with aura, there is endothelial dysfunction. Okay. Then again, in the patient in which there is blood stasis, there is again increased coagulation stasis. So what are the condition in which blood is getting blood flow undergoes stasis? Is atherosclerosis, okay, hyperlipidemia, in the heart diseases, and after surgery, because patient is more so in a resting phase. Okay, so these are the four conditions in which there is stasis is in the blood flow: atherosclerosis, hyperlipidemia, heart diseases, and after surgery. And sometimes the body has its own hypercoagulability conditions, like in the postpartum phase. You all know all coagulation factors increase in pregnancy and they come to a normal level. Will Yes, I know that two factors they don't increase, 11 and 13, but rest all factors they increase. Yes, so all these factors make the pregnancy a hypercoagulable stage, and these factors comes to normal till 6 weeks. Okay, and again, already if the patient is having thrombosis disease or hereditary thrombophilia or the stroke. Okay, so four factors you have to remember in which endothelial get dysfunction: hypertension, diabetes, smoking, and migraine with aura. Okay, these are all the factors in which endothelial gets dysfunction: stasis in atherosclerosis and hyperlipidemia, heart diseases, and after surgery. And hypercoagulability is seen in thrombosis, hereditary thrombophilia, stroke, and postpartum. Okay, postpartum is very important. The other factors in which the combined oral contraceptive pills is contraindicated is acute liver dysfunction, because estrogen and progesterone, they are metabolized in the liver. Then is lactation, because estrogen component suppresses the lactation, so first 6 months post pregnancy it is contraindicated. And cancers, two cancers, because they increase these two cancer chances: cervix adenocarcinoma and hepatoadenoma. One condition, I don't know why you all think, okay, but in which combined oral contraceptive is not contraindicated, is STD. That is why most of your question get wrong. Please rule out this concept out of your mind, that in STD combined oral contraceptive pill is contraindicated. No, it is not contraindicated. Okay, in STD combined oral contraceptive pills are ideal, they are not contraindicated. Please, already the list is very long, don't increase the list. Now we will see all those conditions in what are the other benefits of combined oral contraceptive pills other than contraception. Okay, first of all, as you have studied in the mechanism of combined oral contraceptive pill, that body's own hypothalamus pituitary ovarian axis is suppressed. So all the hormonal problems related to the bleeding, related to the menstruation, menorrhagia, metromenorrhagia, oligomenorrhea, hypomenorrhea, all this hormonal problems related to menstrual problem, they get correct, because now the body is shifted from own body system to external estrogen and progesterone, and they are being taken daily in a regular amount. So now menstrual and hormonal problems will not be there if the lady was having any problem, and the patient will not have any dysmenorrhea, because dysmenorrhea occurs if ovulation is occurring, but in this case ovulation does not occur, so there will be no dysmenorrhea. Okay, Then hyperestrogenic conditions, as I already told you, the estrogen which we are giving in the combined oral contraceptive pill is much lesser in amount. So all the hyperestrogenic conditions, what are the hyperestrogenic conditions? Uh, fibroid, adenomyosis, endometriosis, or endometrial cancer, ovarian cancer, all these hyperestrogenic conditions, benign conditions and cancers, they will be benefited. Their risk will get decreased, or they will get correct. Okay, and though no doubt breast cancer is also a estrogenic cancer, but there is no effect on the breast cancer. Okay, now we should know what are the ideal conditions for giving combined oral contraceptive pills. Okay, so all those conditions in which copper T is contraindicated. What are the conditions in which copper T is contraindicated? They are given here in the green circle. Okay, India's top ABCD is the mnemonic. I stands for PID or puerperal sepsis, T stands for trophoblastic diseases, A stands for anomalies of uterus, and B stands for bleeding, undiagnosed vaginal bleeding, C stands for cancer cervix and cancer endometrium, D stands for diabetes mellitus with vasculopathy. Okay, so now the copper, all those conditions in which copper T is contraindicated, all those conditions in which copper T is contraindicated, combined oral contraceptive is a ideal condition. You all know that copper T cannot be placed in a newly married couple, so there also the combined oral contraceptive pill is there also the combined oral contraceptive pill is ideal. Menstrual problems, dysmenorrhea, and all these hyperestrogenic condition, the combined oral contraceptive pill is ideal condition. The another slide is about the mist pill. Okay, so here I want to tell you, first you need to know two things: how much time it takes the contraception to comes. If we give this drug on the first day itself of period, first 5 days of the periods, then the contraception action comes immediate. But if we miss that 4 days, initial 4 days, then it takes 7 days for the contraception action to come. Okay, it means if a female takes a pill for 7 days, then its contraception action will come, and this contraception action, in absence of the pill, it goes in 2 days. So if one who is taking the combined oral contraceptive pills misses the pills for 2 days, then the contraception action goes. Okay, so with this knowledge we are proceeding how to manage with the missed pill. So if one pill is missed, we know that nothing will happen. Take the next pill whenever one remembers, because we know that contraception action of the pill goes in 2 days. Okay, what if more than one pill is missed, that is two pills are missed or more than two pills are missed, then whenever you remember, take that pill. Okay, and now additional contraception will be taken for 7 days, because now we know that contraception action is gone if we have missed the pill for 2 or more than 2 days. Now next contraception action will come after 7 days. Okay, and additional measures can be done. And for example, if the pill is missed in the first week, it then has high chances, if more than two pills are missed in two or more than two pills are missed in the first week, then we have to take emergency contraceptive if there was a history of intercourse in the past 72 hours. Okay, and in the second week we have to do nothing, and in the third week we have to miss the pill free period. Okay, how we give oral contraceptive pills? We give the pill for 21 days, and then we give 1 week break, then we give it for 21 days, and then we give 1 week break. So this pill free period will be omitted, will be missed. The lady has to take the pills regularly if the lady miss more than two pills in the third week. Okay, so contraception failure occurs, or combined oral contraceptive pills, they fails when we are taking the drugs in which the metabolism enzymes they are in which the drugs in which the metabolism enzymes they are they get activated. So this combined oral contraceptive pills will be metabolized early. So those drugs are rifampicin, aminoglycosides, and barbiturates. If any patient taking combined oral contraceptive pills take these drugs, then combined oral contraceptive will fails because the enzymes which metabolize them will get activated and they will lead to less efficiency of this. Now what happens now, copper T, this is a very important question. What happens when copper T thread is not being filled? In that condition there can be three conditions. Number one is either the copper T has expelled, okay, then we have to do nothing. Okay, now the another two condition is that if we are not finding the thread, then we'll get the TVS or ultrasound done. Okay, and if the copper T is in the uterus, then we have to remove that copper T with the hook. But if that copper T is in the peritoneal cavity, then we have to remove that copper T laparoscopically. Okay, so if we are not able to appreciate the thread, okay, then three conditions are there: either that the whole copper T has been expelled out from the uterine cavity, or only the thread has break and the copper T is in the uterus, or the copper T has perforated in the peritoneal cavity. Okay, now if the copper T has perforated in the peritoneal cavity, then of course we will approach the peritoneal cavity by laparoscopy, and if laparoscopy get fails, then we will do laparotomy. And if the copper T is already in the uterus, then we will remove that copper T with the copper T hook. But copper T hook does not function in the peritoneal cavity, and if we get fail by removing it by copper T hook, then we will remove it by hysteroscopically. Okay. Contraindication of copper T. Now you all know this mnemonic. India's top ABCD. I stand for infection, PID, puerperal sepsis. As you all know, copper T has a tendency to cause PID. So if already a patient is suffering from PID, then we will not give this. Not insert the copper T. The another condition is trophoblastic diseases, as uterus is very soft. So if you will put the copper T, the uterus will get perforated. The another is anomalies of uterus, only uterus anomalies. We already studied today, Mullerian anomalies. B stands for bleeding, undiagnosed vaginal bleeding is there, then we are not going to insert copper T because there can be cancers inside. Cancer, uterine and cervix we will not give because the copper T can cause sepsis. And diabetes mellitus with vasculopathy we are not going to give. As you have seen, we are not giving combined oral contraceptive pills and copper T in both the conditions. We are not giving in diabetes mellitus with vasculopathy the copper T was contraindicated, and in diabetes mellitus with vasculopathy combined oral contraceptive pill is contraindicated. So what contraception we give in combined oral diabetes mellitus with vasculopathy? So we give which contraception will give? We give barrier methods. Okay, double barrier is to be used by male also and by female also. So what are the ideal conditions? So first of all, this is a long and reversible method, so it's the best method to have space between the two childs. Okay, so you remember combined oral contraceptive was ideal for the newly married couples, but this copper T is ideal for spacing the child, that is in the Paris woman. Okay, and as one does not need to remember I have to take pill every day in the case of the copper T. So if the patient is unmotivated, then again a copper T is ideal. And all the contraindication of combined oral contraceptive, that long list of hypercoagulable tendency, the liver dysfunction, the lactation and the cancers, it is it can be given. Okay, so all the conditions. uh, So what happens if puberty fails and pregnancy occurs? So if occurs, then two questions are there: whether we have to continue with the pregnancy or not, and the second question is whether we have to remove the puberty or not. So answer to the first question, whether we have to continue the pregnancy or not, it lies in the hand of patient, because there are 50% chances of abortion and there are 50% chances of survival. Then if the patient wants to continue the pregnancy, then patient can continue. If the patient does not want to continue the pregnancy, then it depends on patient. Now the answer to the second question, that whether we will remove the puberty which is present with pregnancy or not. So answer to this is, if the thread is felt at os, then we will pull that thread and we will remove it. If the thread is not visible, then we are not going to do any intervention. So whether we are going to remove the puberty or leave the puberty in the uterus depends that whether the thread is visible at os or not. If it is visible, then we will remove it. If it is not visible, then we will not remove it. Okay. Next topic is progesterone only contraceptive. Okay, now let's start it. First of all, what are the main features of progesterone only contraceptive pills? The main features are that it does not affect lactation. Okay, and progesterone only contraceptive pill, it does not affect lactation. Okay, and there is endometrial atrophy occurs because we are giving the progesterone from first day. So what is the function of progesterone? It's don't let the endometrium to proliferate, and it stabilize the endometrium. So due to this effect, and we the endometrium does not get proliferate and endometrial atrophy is there. Okay, so most common side effect of progesterone only contraceptive is that there is irregular bleeding. Okay, and what is their mechanism of action? Anovulation and thickening the cervical mucus. Now let us see various progesterone only contraceptive pills. Progesterone only pills, POP or mini pill, which we say, in the patients, the clients, they didn't give the good compliance. Because if this pill is missed for 1 hour also, its contraception action goes. Okay, so the good compliance was not with these pills. Now then because the progesterone only pills contraception action goes when they are missed even for 1 hour, so the sustained release preparations came into the market. One of the sustained release preparation is injection depot medroxyprogesterone acetate. It is given once in 3 months, and progesterone is injection in this injection is depot medroxyprogesterone acetate. And the another is the implant imiplenon. Okay, here the progesterone is desogestrel, and this is the implant. Single rod is there that we give in the left arm. We implant this implant here subdermally in the left arm, and this is the contraceptive method imiplenon, which has the most least Pearl index. Pi is here stand for Pearl index. It is only 0.05, and it is much less than tubectomy and vasectomy. The progesterone in the imiplenon is desogestrel. Okay, then you all know there is one progesterone intrauterine device which is Mirena, and it contains a progesterone levonorgestrel, and it works for 5 years. Okay, the total, once it was asked, I don't think there is a sense of learning it. If you want, you can learn. The total progesterone levonorgestrel is 52 mg, and there is daily release of 20 mics. Now let's study about sterilization. First we will study about the tubectomy. So the fallopian tube is ligated and then cut in the tubectomy, and it is usually ligated at isthmus because chances of recanalization are maximum, okay. And the fallopian tube is approached by, either by laparotomy, then it is known as mini lap, and this or either it can be approached by laparoscopically, then it is known as laparoscopic tubectomy. Postpartum tubectomy is a tubectomy which is done after the delivery up till 7 days. After 7 days, we can't do tubectomy, and in postpartum tubectomy, laparoscopic tubectomy is contraindicated. Only mini lap can be done, and that is also done up till 7 days only. Okay. Then interval tubectomies are done, that is after 6 weeks of the delivery. Okay. The most common mini lap method which we use is modified Pomeroy. In this, we hold the fallopian tube with Babcock's forceps. We ligate it by the suture, and then we cut the fold which we have ligated, and we keep the thread there itself. Vasectomy, only two important things you have to remember about vasectomy. Number one is that sterilization is not immediate. It is after 3 months or 20 ejaculation, and we have to confirm the sterilization by semen analysis, by agiospermia in the semen analysis. And second is, for that 3 months we have to give the couple condoms. Okay, no abstinence is to be said, because abstinence advice is not practical. Calendar method or billing method or rhythm method, they are one and the same thing. Here no contraceptive method is used. It is also known as natural method. Okay, this is based on the fact that ovulation, ova gets ready for fertilization at near 14th day, and at near 14th day, and before the ova gets ready, the cervical, under the effect of the estrogen, increased estrogen, the cervical mucus thins, right? And that is why it is this is all that this knowledge is used, that and it is said 7 days, first 7 days are safe. Yes, first 7 days and last 7 days are safe. Okay, and it has a high failure rate. Okay, and first 7 days and last 7 days are safe, because in between period the ova was getting ready for the, it can ovulate and conceiving can occur. So first 7 days and last 7 days are safe, and ovulation is appreciated by some ladies by the wetness in the vagina and by the increase in the temperature, because progesterone is the thermogenic hormone. Increase wetness in the vagina is due to estrogen. Estrogen makes the mucus, cervical mucus, thin. And increase in temperature is due to the progesterone, because progesterone is a thermogenic hormone and temperature is only increased half degree Fahrenheit. Okay, now let's study emergency contraception. As already discussed, emergency contraception is the contraception which we give after the coitus has occurred and before implantation. So all these drugs of emergency contraception are given in high doses, because the gap between the fertilization and implantation is only 6 days. So all the emergency contraceptive drugs, they have to act in 6 days. So all the high doses are given. So of course the high doses of hormones, estrogen, progesterone we will give. Okay, So when high dose progesterone is given, the hormone is levonorgestrel. The progesterone of choice is levonorgestrel. It can be given within 72 hours of the unprotected intercourse. And this high dose progesterone or high dose levonorgestrel, it prevents the implantation, and thereby the conceiving does not occur. And the dose which we give is 1.5 mg. You have to remember, the questions have asked on it many times. High dose estrogen can be given up to 72 hours, but practically it is not given because estrogen causes loss of vomiting. Estrogen and progesterone in combination can also be given, and that is what is UGP regimen. Okay. Mifepristone, which is an anti-progestin, and its another name is RU486. It also prevent implantation, and it is also active only up till 72 hours of intercourse, and its dose is 10 to 50 mg. Okay. And the fifth method is ulipristal tablet. Its dose is 30 mg, and it is basically a SPRM, selective progesterone receptor modulator. The sixth method is copper T. This ulipristal and copper T, they can be given up till 5 days of unprotected intercourse. So they can prevent implantation up till 5 days. Okay. So once again, I would like to tell you the doses. The dose of the levonorgestrel, the emergency contraception of choice, the emergency contraception approved by the government of India is levonorgestrel 1.5 mg or I-pill unwanted 72 pill. Okay. And the another method which is highly common in India is copper T, which we can give for 5 days of intercourse. Okay. Pearl index. Let's study now the pearl index. The pearl index of copper T is 0.5. The pearl index of combined oral contraceptive is 0.6. It indicates all the pregnancies which occur in spite of using these contraceptive method. Pregnancy which occurred, and it is expressed in 100 women year. Okay. If that particular contraception, if it is used by 100 women for 1 year. Okay. What is the contraception pearl index of progesterone contraception? It is 1 to 2. Tubectomy it is 0.2. Vasectomy it is 0.1. Barriers it is 20, and natural method it is 25. Okay. And imiplanon, as I have already told you, it is 0.05. It is least among the all. It is 0.05, and the Mirena, it is 0.2, equal to tubectomy. Okay. Now the last in the contraception is the barrier contraceptive. As you all know that in the barrier contraceptive there are condoms, male and female condoms. Then there is cervical caps and diaphragm. Okay. Can be used by females. Okay. What is the shape of cervical caps? They are like this hat shape. I think pen is not working, so we will see it when it works. Okay. So barrier contraceptive pills mean just the shape of the cervical caps is hat like, and the diaphragm they are of semicircular type. Okay. Rings and patches they are The rings and patches, they are combined hormonal contraceptive. They are not barrier contraceptive. Okay. Now in the last phase, the pen is not working, so you have to cooperate with me. So pen will not work. I have written make all the slide. That's good. Oncology. So most common genital cancer is CA cervix, because CA cervix is affecting very large number of females. So that is why the all the females, they should undergo screening. Okay, so that CA cervix can be diagnosed at much earlier stage. And moreover, the CA cervix has a long latent period of 10 to 15 years. So it gives us a 10 to 15 years time to prevent that cancer. Okay, so it gives 10 to 15 years time to prevent that cancer. So that is why screening is getting very successful. So first of all, there are two type of human papilloma virus. So you all know human papilloma virus cause CA cervix. So there are two types of human papilloma virus: high risk type and low risk type. High risk type is the type which contains 16 and 18 HPV. Okay, penile, and they cause CA cervix. In addition to CA cervix, they also cause other cancer. Below the cervix, there is vagina, CA vulva, then CA anus, then the male genital cancer, penile cancer, and the last cancer is the oropharyngeal cancer. So it causes lot of it causes increased number of cancers. So it causes increased number of cancers. Okay, then the another cancer which is caused so the another type of human papilloma virus is a low risk type. It contain only two serotypes, 6 and 11, and mainly they cause genital warts and laryngeal papillomatosis. Okay, we have also developed vaccines against some serotypes. The Cervavax vaccine is against serotype 16 and 18. Gardasil vaccine is against 4 serotypes, 6, 11, 16 and 18. And Gardasil 9 or nonavalent is against 6, 11, 16, 18. And in addition to that, it is also against the more 5 serotype: 31, 33, 45, 52 and 58. Okay, so there is a odd even thing: 31, 33, 45. First three are odd, and the last two, 52 and 58, are even. Okay, now there are two type of genes in the HPV: E gene and L gene. E gene means early gene and L gene means late gene. Out of this E gene, only two genes are important: E6 and E7, because they are responsible for malignant transformation. And out of L gene, L1 is only important, because L1, it makes capsid protein, the protein which helps in adherence of the human papilloma virus to the which helps in adhering of the human papilloma virus to the cervical epithelial cells. Okay, now while we are preparing this vaccine, we target L1 gene. Okay, so I don't know why you all take E6, E7 gene. We don't target E6, E7 gene while making vaccine. We only target L1 gene, because with the help of the capsid protein, the virus adheres to the cervical epithelial cells. So if adherence will not occur, then if the adherence will not occur, then the whole process of virus attack will not occur. Okay, so you all know that pap smear is the method to screen the CA cervix. Here first we have to retract the vagina, then with the help of air spatula we have to scrap the cells of the transformation zone. ठीक है. Transformation zone, we have discussed it already. What is transformation zone? The zone between the old squamocolumnar junction and new squamocolumnar junction. The zone in between is a transformation zone. Okay. Now here, then after scraping the cell from the transformation zone with the help of air spatula, we have to put those cells on the slide. A very thin slide it should be there, and then very fastly we have to fix that slide with a fixative. The fixative which is used is 95% ethyl alcohol. The fixative which is used is 95% ethyl alcohol. Okay. In which ladies this pap smear skinning is done 21 year to 65 years, and it is done 3 yearly. Okay. And after 29 years it is done, it is advised that you get the HPV DNA with pap smear done every 5 yearly. But as HPV DNA is a quite costly procedure, take few thousands rupees. So if one is not able to afford it, then one has to undergo pap smear every 3 yearly. Okay, once again, which all ladies they have, we have to screen by pap smear 21 to 65 years lady. Pap smear is to be repeated every 3 yearly. After 29 year, it is advised to get HPV DNA and pap smear done every 5 yearly. But one can, if cannot afford it, then pap smear is to be done every 3 yearly as always. Now, what are the results of this pap smear? Either it will come low squamous intraepithelial lesion, or it will come ascus or CIN1 if 1/3 of the cells are involved. Then what we will do? We will get the pap smear done every 6 months. We will get the pap smear done every 6 months, and we will also get the HPV DNA done. Okay. And if the result of it is HSIL, high squamous intraepithelial lesion, or CIN2-3, then we will perform the colposcopic guided biopsy. It means some problem is there inside. How we do colposcopy? Colposcopy is basically a camera, and we take images of the cervix. It is a magnifying camera. So first of all, we see the cervix under magnification to note if any ulcer which was not visible on naked eye. Next is we apply the iodine on the cervix, right? The hyper dividing cell, the dividing cell, rapidly dividing cell, they have low glucose because glucose is utilized while they are dividing. So the cells, they will not be brown, because under the effect of the glucose, the iodine changes into brown color, mahogany brown color. But the cells which are rapidly dividing, they have less glucose because they have utilized their glucose, so they will be stained mustard yellow. Okay. What will happen? Then we will apply the acetic acid. What happens when we apply the acetic acid? Then the rapidly dividing cells, as they have we have studied, they have less glucose, they have high protein, high DNA, high RNA. So the proteins, they coagulates by the acetic acid, and that area, rapidly dividing area, that turns white. Okay. Then in the last, we will apply the green filter, green color light we will throw, green filter. Under the green color, the rapidly dividing cell, they have increased blood vessels, and those blood vessels, they look like white color. Okay. So these are the 4 methods, 4 measures we do while we perform the colposcopy. Other screening methods are, but colposcopy is not a screening method. Pap smear is a screening method. Okay. So we do colposcopy to find the lesion, and if the report is of CIN2 and CIN3. Okay. So other screening method to screen CA cervix is via visual inspection of acetic acid. Here we are not using colposcope, we are just applying acetic acid and we are looking for those white areas under the naked eye, and this is a very cost effective screening method. Villi is visual inspection of lobules iodine. Again we are looking for the mustard yellow colors. Now how the different cancers present, we should know that we will not be studying the screening of endometrial and ovarian cancers as they are not common. We will study only CA cervix screening. Okay, so now we are normally we sit in OPD for the patients. Now when a patient with which complaint the CA cervix comes, CA cervix patient comes with irregular bleeding. Now what happens in CA cervix? Cervix multiplies, grows, so that cervix multiplication, it bleeds. Okay, so and the patient complains of irregular bleeding, and irregular bleeding is the most common symptom. And when we will examine the patient, then we will and when we will examine the patient, then we will have a growth on the cervix, a growth. Okay, cervix will be unhealthy, there will be a proper growth on the cervix. What happens in the CA endometrium? In the CA endometrium grows, so the patient will suffer from menomatorrhagia. What is menomatorrhagia? Metorrhagia means irregular bleeding between the periods, and menorrhagia means increase bleeding in periods. So both will occur. Increased bleeding in periods will also occur because endometrium is proliferating, and metorrhagia will occur in between also the endometrium. That hyperproliferated endometrium will shed off, and of course the patient will have prolonged cycle. And if the patient has undergone menopause, then the patient will come to us with the post-menopausal bleeding. I forgot to tell you that CA cervix patient also presents with post-coital bleeding, because it hyperdividing of the cervix, it bleeds when intercourse is there. Okay, so the ovarian tumor patient, it presents with pain abdomen, because usually the ovarian tumor, it grows very large, it is very cystic, and the patient has pain due to that large mass, and it is also accompanied by ascites. So let us see all the risk factors. The risk factor of CA cervix, the main cause of CA cervix is HPV. So HPV is transmitted to a female by a male. I always tell you, a female who has never done intercourse will never have CA cervix. More is the sexual activity, more is the chance of having CA cervix, more is the chance of having HPV transmission. So here we will rule out the increased sexual activity factors. What was the first age of the child? What was the first age of intercourse? More early the sexual life start, more are the chances of HPV transmission. How many children you have? More is the sexual activity, more children are there. Whether the patient is suffering from any STD or not, then we will ask that. We know that low socioeconomic strata, they have no other source of entertainment. Usually they have sexual activities only their entertainment source. So low socioeconomic status, and the one thing which was left was immunocompromised patient. So immunocompromised patient is prone to each and every cancer, including CA cervix. Okay, so CA endometrium, what is there? You know that increased endometrium proliferation is there. If already the factors which are present, which are increasing the endometrium proliferation, then there will be increased risk of CA endometrium. So whenever you know that estrogen is responsible for endometrium proliferation, and progesterone always stabilize the endometrium proliferation. So if increased estrogen or unopposed estrogen is there, then there will be Then there will be CA endometrium increased chances. When there is increased endometrium proliferation, when there is early menarche, late menopause or nulliparous. Early menarche periods start very early, so there will be increased endometrium proliferation. Same is the condition with the late menopause. And you all know pregnancy and lactation, it gives a rest to endometrium proliferation. Okay, so these are the nulliparity is a risk factor for the endometrial carcinoma, because then there will be no risk. Okay, okay. Now next is the unopposed estrogen, which is in the case of HRT and tamoxifen. Tamoxifen is a SERM, selective estrogen receptor modulator. It is anti-estrogenic on breast, so it is given in the breast cancer, but it is estrogenic on uterus, so it causes endometrial cancer. It was a question of FMG 2022 June. Okay, HRT has lot of estrogen, so HRT prones a patient to endometrial cancer. So usually HRT is given along with progesterone to decrease this risk of endometrial cancer. Okay, in the PCOS there is increased endometrial proliferation. Same is the case in granulosa cell tumor. And what is Copper's cancer syndrome? In Copper's cancer syndrome is the syndrome if the endometrial cancer occurs in a diabetes mellitus and hypertension patient. If the endometrial cancer occurs in a patient with diabetes and if the endometrial cancer occurs in a patient with diabetes and hypertension, then that is known as the Copper's cancer syndrome. And it usually occurs because more is the patient hyperlipidemia, more is the cholesterol, more is the patient obese, more is the estrogen formed, and more in the endometrium undergoes proliferation. So one genetic factor is also there, that is the HNPCC. One genetic factor is also there, HNPCC, that is hereditary non-polyposis colon cancer syndrome, that also you have to rule out. Okay, so you have to rule out increased estrogen proliferating, increased estrogen or unopposed estrogen conditions, PCOS, the Copper's cancer syndrome, the obesity, and the any estrogenic drug. Okay. Next is the CA ovary. CA ovary is mainly due to the BRCA mutation or HNPCC. If BRCA mutation is there, the chances of ovarian cancer is at least 50%. Okay. Now, if there is increased ovulation, the chances of epithelial ovarian cancer is high. When is epithelial ovarian cancer high? When there is increased ovulation. So, increased ovulation again occurs in early menarche, late menopause, and nulliparous lady, because when a patient gets pregnant, then there is rest of ovulation also. Okay, early menarche, because more is the lady will attain the menarche, more is the chance of, more early the patient has menarche, more will the patient ovulate. So more are the chances of epithelial ovarian cancer. Okay. Now all these patients, they come with their complaint. Now we must know what are the confirmatory tests, which test we will diagnose to these suspicious patients. Okay, the test which we will do for this suspicious patient is, for the patients which are coming with the complaints of CA cervix, irregular bleeding or postcoital bleeding, we will do the colposcopic guided punch biopsy. And if we see any growth, then of course we are going to do the punch biopsy directly. If we are not able to appreciate the lesion, then we will do colposcopic guided biopsy, and if we are able to appreciate the lesion, we will do the punch biopsy. In the case of CA endometrium suspicion, we will do the endometrial biopsy. And in the case of the ovarian tumor, the patient which was coming with the increased ovarian mass, we will get the ultrasound done to confirm that ovarian mass, and we will also get the tumor markers done. Okay, Now let us see what are the tumor markers of the ovary here. Questions are coming on this topic. Please focus. It's a very small topic. See, the ovarian tumors, they are mainly of the three type. Epithelial, if the epithelium of the ovary, if the epithelium of ovary becomes cancerous, then it is the epithelial ovarian tumor. Epithelial ovarian tumor, the subtypes are the epithelial ovarian tumor, the subtypes are serous, mucinous, Brenner, and clear cell. It is said that during ovulation, the epithelium it ruptures, right? It tears. Then the ova it jumps into the fallopian tube from the ovary. Okay, so if at that time it is acted upon by the fallopian tube growth factors, then it is serous. Or if it is acted upon by the cervix growth factor, then it becomes mucinous. And if it is acted upon by the bladder growth factors, then it becomes Brenner. And if it is acted by some more cancerous, then it becomes clear cell. Usually epithelial ovarian cancers, they occur in a 55 years lady. This makes a large mass in the ovary. Epithelial ovarian cancers, they are the 90%. They makes the 90% of the whole ovarian tumors. Okay, so epithelial ovarian tumors, they are 90% of the all the tumors, so they are the most common tumor. And out of all these, serous, mucinous, Brenner, and clear cell, serous is the most common. Okay, so which are most commonly most commonly tumor you will see in the lady of 55 years. Or any lady. Which ovarian tumor is most common? Serous cyst adenoma. Okay. Now germ cell is a tumor, ovarian tumor, which occurs in a 25 years old lady if germ cell undergoes growth. Okay. So now you know that germ cell make three things. Germ cell makes fetus, germ cell makes placenta, and germ cell makes yolk sac. If the part of the germ cell that is making fetus, it undergoes it multiplies, it undergoes growth, then it is known as teratoma. Of course, this is the most common germ cell tumor. It is usually benign. So most common germ cell tumor is teratoma, and most commonly this teratoma is benign, and it is also known as dermoid cyst. In this cyst we see three germ cell layer products. Okay, like teats, the alveoli, okay, and thyroid tissue. If thyroid tissue is seen, then it is if thyroid tissue is seen, then it is stroma ovari. Okay, if yolk sac tumor is formed, the part of the germ cell which makes the yolk sac, it gets tumorous, then yolk sac tumor is formed. The another name of it is endodermal sinus tumor. The tumor marker of it is alpha fetoprotein. The Schuller-Dewey bodies are formed. So as you all know, in the Schuller-Dewey bodies, there is a sinus at the periphery. Okay. The third type of the germ cell tumor is choriocarcinoma. Choriocarcinoma, there is increased HCG formation. This choriocarcinoma is also known as non-gestational trophoblastic neoplasia. Okay. Now the fourth type of the tumor is of germ cell tumor is a dysgerminoma. In the dysgerminoma, fourth type of the tumor is a dysgerminoma. What is dysgerminoma? Here the primordial germ cell, it becomes tumorous. It is the most common malignant germ cell tumor. Most common malignant germ cell tumor is dysgerminoma. Most common germ cell tumor is teratoma. Most common benign germ cell tumor is teratoma or dermoid cyst. The tumor marker of this dysgerminoma is LDH. Okay. So what is the tumor marker of epithelial ovarian tumor? CA125. What is the tumor marker of yolk sac? Alpha fetoprotein. Or endodermal sinus tumor, alpha fetoprotein. Choriocarcinoma, HCG. And this germinoma, it is LDH. The third type of ovarian tumor is the follicular cell tumor. Follicular cell tumor, or as you know, follicles are made up of two cells, mainly granulosa cell and theca cell. If granulosa cells they become tumorous, then it is known as granulosa cell tumor. The tumor marker of it is inhibin B. You all know inhibin B is made by the granulosa cell secretes estrogen and inhibin B. So inhibin B is a tumor marker of the granulosa cell tumor. The another tumor of follicular cell is the theca cell tumor. The third type of tumor is Sertoli Leydig cell tumor. Here the masculinization of female occurs. It is also known as arenoblastoma. The last tumor of the follicular cell tumor is a fibroma. If the fibroma is benign and it is also accompanied by ascites and hydrothorax, then it is known as the Meek syndrome. Okay, what is Meek syndrome? If this fibroma is benign and it is accompanied by ascites and hydrothorax, then it is known as the Meek syndrome. Now we have sent some reports. Okay, so for the suspicion of CA cervix, we have done the punch biopsy. So on the punch biopsy report, it can come a pre-malignant lesion or cancer. So what we will do for pre-malignant condition, if on the punch biopsy CIN2 and CIN3 is coming on the punch biopsy, the pre-malignant condition is coming, then we will do LEAP. Okay, if invasive cancer comes, okay, it means it has crossed the basement membrane, it breaches the basement membrane, then we will do conization. It is a therapeutic indication of conization is invasive cancer on the punch biopsy report. If the report comes squamous cell carcinoma of the punch biopsy, then it is a cancer. Now we will do clinical staging. Okay. Now what we will do for the endometrial biopsy report? So the pre-malignant lesion for the endometrial cancer is endometrial hyperplasia. It can be simple or complex. It can be without atypia or with atypia. If it is simple endometrial hyperplasia without atypia, then the chances of endometrial cancer to become in future is 1%. If it is complex endometrial hyperplasia without atypia, then the chances are 3%. If it is simple hyperplasia with atypia, then the chances are 8 to 10%. Okay, and if it is complex hyperplasia with atypia, then the chances of cancer are 30%. If on the pre-malignant lesion it is atypia, whether it is simple or complex, then it can be treated only and only by progesterone. I can't write because my pen is not working, touch has gone from this tab. Okay, so but if atypia is present, then we have to undergo hysterectomy. Okay, because chances of cancers are very high, 10%, 30% chances are there. Okay, but if it is without atypia, then we can treat this patient by a progesterone. But of course, if family is completed, then patients they don't want long progesterone therapy, then they want hysterectomy itself. But if family is not completed and there is no atypia on the report, okay, then we can treat it by progesterone. Adenocarcinoma, and if on the endometrial biopsy report it comes adenocarcinoma endometrium, then we will do surgical staging. And if in the patient of ovarian tumor, the tumor markers they came out to be positive, then again we will do the surgical staging. Only in the CA cervix we will do clinical staging in the ovarian tumor and in the endometrial carcinoma we will do the surgery. Which surgery we do in the endometrial adenocarcinoma? Hysterectomy with bilateral salpingo-oophorectomy. Okay. Which surgery we do in the ovarian tumor? Or if the tumor markers come positive, of course we will do debulking. Okay. And if ascites is there, or then we will get that ascitic fluid biopsy done. Or if it is not there, then we'll get peritoneal washing biopsy done. Other than this fluid biopsy, we will also get retroperitoneal lymph node removed and get their biopsy done, and we will also get omentum removed and get their biopsy done. Okay. So in addition to debulking, we are going to get this 3 biopsy done in the case of the patient of the ovarian tumor. Okay. Now let us study how we will do staging. We are here studying the CA cervix cancer. The CA cervix, as you all know, it spreads by lymphatic spread is there more commonly. Okay. So in the first stage of every cancer is if it is limited up till to that organ. So CA cervix stage 1 is if it is limited up till cervix. 1A is micro lesion less than 0.5 mm. 1B is if that lesion is more than 0.5 mm, then we can see it with our eyes, and then we will stage it at stage 1B. Okay. Stage 2A is, I already always told you that we will make a circle. Not see, this is uterus. So this is uterus. Okay, you will make a circle and you will dissect the vagina into upper 2/3 and lower 1/3. So the part which are coming into that circle is cancer cervix stage 2. 2A is upper 2/3 of the vagina and 2B is parametrium. Stage 3 is which is outer to the circle. 3A is lower 1/3 of the vagina, pelvic wall, and 3C is pelvic and para-aortic lymph node. Okay. Once again, all the structures which are outer to that circle, okay, then they come in stage 3. Lower 1/3 vagina is stage 3A, 3B is pelvic wall, and 3C is pelvic and para-aortic lymph node. Okay. Stage 4A is bowel and bladder, and stage 4B, there was no space left, so I'm telling you verbally. 4A is bowel and bladder and 4B is distant metastasis. The lymphatic spread of the CA cervix, the mnemonic for the lymphatics is HOPES. H stand for hypogastric, O stand for obturator, P stand for para-cervical or uterine lymph node. Okay. E stand for external iliac, not inguinal, and S stands for sacral. So this is a mnemonic. Most common lymph node which is involved is obturator, and the sentinel lymph node is paracervical. Okay. The cancer, endometrial cancer staging. So first is if it is limited to endometrium and myometrium, stage 1A is less than 50%. So the mode of spread is direct spread, that is organ to organ. 1A is endometrium and half of the myometrium. 1B is myometrium more than 50% involved. Stage 2 is cervix. Stage 3A is, now we will go to serosa and adnexa. 3B is vagina. This vagina is asked quite often. Rest all staging after 3B is similar to the CA cervix. Stage 3C is para-aortic and pelvic lymph node. Stage 4A is bowel and bladder, and stage 4B is distant metastasis. Okay. Ovarian carcinoma, stage 1 is usually ovarian carcinoma staging is not asked. We will have just a limited review. Stage 1 is it spreads cavity wise. Stage 1 is if it is limited to ovary. Stage 2 is in the pelvic cavity. They can ask you pelvic organ, or they can ask you pelvic lymph nodes. All that comes in stage 2. Stage 3 is abdominal cavity except deep liver and spleen. Stage 4 is pleural cavity or rest of the body. Okay, that was all about the ovarian cancer. Now the last slide, it is about the treatment. Okay. Okay, you just focus here. You will learn the treatment in 1 minute. See, for the CS cervix treatment, you have to remember the figure 2A. ठीक है, before 2A we do surgery, and after 2A we do chemoradiation. Okay, ठीक है, chemotherapy will not be sufficient. We have to give radiotherapy, but before radiotherapy we give IV chemicals, because that they increase the sensitivity. So the procedure is known as chemoradiation. So before 2A, so up till 2A it is surgery. And what surgery we do in CS cervix? Because we did the clinical staging, and if we find the stage 2A or before 2A, we will do surgery. What surgery we will do? Yes, we will do Vertime cystectomy, right? And if the family is not complete, we can do trachelectomy, in which we ampute the cervix, remove the cervix. Okay. Now after 2A, we have to give chemoradiation. What is the treatment of CA? Endometrium. Here we have to learn the word 1A. Up till 1A we do surgery, and after 1A we do radiotherapy, and in the advanced 3rd, 4th stages we give chemotherapy, radiotherapy, hormone therapy. Okay, but you just need to know surgery is sufficient up till 1A, because endometrial cancer we do surgical staging. So already we have done the surgery. Okay, so which surgery we do in the C endometrium? Hysterectomy with bilateral salpingo-oophorectomy. Okay, now after 1A, what we will do? We will give radiotherapy. In the advanced stages we give all the treatments. Okay, CA ovary up till 1A we do surgery is sufficient. Here also we have done the surgery. Surgical staging we did not. So after 1A we will give chemotherapy. CA ovary, all cancers are radio resistant except desjaminoma. Most sensitive organ for radiation is ovary, but the cancers which are radiation resistant